Patient of yours can have prediabetes for 5 to 10 years.
Carnivore increases heart disease risk.
The average cardiologist has no idea that a third of people's cholesterol is going to go down. Drinking more water than your thirst dictates is not healthy.
Other medical conditions that you have seen improved, reversed, or stopped for people being on carnivore.
Exercise can lower your insulin level.
Hey, Dr. Barry, welcome to Born Unstoppable. It's a pleasure meeting you, and I'm looking forward to asking questions and having a good conversation.
Absolutely. It's a pleasure to be here. Thank you.
So I have a long list of different categories of questions, but before we start there, like what's going on? Is there anything new going on in your life, or any? I know there's a new documentary that you've been on that you wanted to kind of just share.
Yeah, so we just released the new documentary called Animal, and it's available, I think, on Amazon and all over the place. Actually, it's been released worldwide now. So if it's a documentary that I'm in it, and there's several other doctors who espouse either a very, very low carbohydrate diet or a carnivore diet. And I think it's going to give people a lot of kind of background information about why it's okay to give this a try. If you've tried multiple other diets and nothing seemed to work, or certain diets make your conditions, your medical conditions, much, much worse, then you really probably ought to look at a carnivore diet, at least temporarily, if not lifelong. And that's what we talk about in that documentary. Also, I know you and I didn't discuss this yet, but I just got a new book that's now available for pre-sale called Common Sense Labs, that I think is really going to help patients and empower patients to have a conversation with their doctor. Because, as a physician, if you don't check the right labs, then you can be completely blind to severe medical conditions that your patient might have. And you have no idea, because some disease processes are quite subtle. They don't have kind of hallmark symptoms. And so I'll give you just one quick example that I cover in this book very thoroughly, is the test called a fasting insulin. And so a patient of yours can have pre-diabetes for 5 to 10 years and their A1C still be normal, because you're checking their labs fasted, right? And so their fasting blood sugar's going to be either normal or maybe just 1 or 2 points high, because they haven't eaten since the night before. And if you check an A1C, it might be 1/10 of a point elevated, and there's your they have prediabetes. But for 5 to 10 years, the insulin level is going to be elevated before the A1C. And so I consider someone who has elevated insulin, but still has a normal blood sugar and a normal A1C, I consider that patient to be pre-diabetic. And most doctors, when patients ask them for an insulin test, the doctor will either say, I don't even know how that would help. I wouldn't know how to interpret it. Or they say, oh, you don't need that. Don't worry about that. I'm checking everything you need. So this patient's running around doing damage to their body, permanent damage with prediabetes, and they have no idea. The doctor has no idea. When the limited amount of labs come back that the doctor did check, everything's normal. So the patient gets a call, hey, everything's normal. We'll see you next year. So now they've got this false, whatever they're doing in their life, whatever diet they're eating, whatever lifestyle they're living, they get this false feedback from the physician. Hey, everything's great. Which the patient takes as an implication. Okay, my diet is great. My lifestyle is great. Everything I'm doing is great. Just keep doing that for another 12 months. And there are multiple ways that doctors can drop the ball. And in the past, patients were kind of stuck with just doing what their doctor said. But I think that the recent events in 2019 and 2020, 2021 have opened so many patients' eyes that, it's probably not smart to just blindly trust your doctor. You probably ought to at least look into it a little bit. And I think a lot more people are doing that. And that's the kind of person this book is for.
Yeah, and I'm glad that you brought that up, because I was going to bring it up too, in terms of, if you talk to your family doctor or any doctor about fasting insulin, because I've asked my supervisors. For those who don't know me, because I think most of the viewers will know you for sure. I just finished my family medicine residency like a week ago. So it was my first week kind of off. And I've been always kind of testing my supervisors to see where their knowledge is and their comfort levels. And I have, one of them is very comfortable with metabolic stuff. I've even did like a small research project assessing the prevalence of metabolic disease within our resident family medicine teaching unit, which is about 30%, like
Yep. Yep.
that fit the criteria. And then about 80% have at least one metabolic factor. But, I asked the supervisor to say, why would you test the fasting insulin? Because you're just going to tell them to do the same thing anyways, right? Change your diet and lifestyle. But I think it's one more data point to encourage the patient and also for the doctor to kind of monitor over time that they can use to encourage them to, eat healthier, exercise. It's a reminder. Whereas if you just say, eat healthy, exercise, your A1C is normal, like you said, people think they're okay, but it's just that slow rumbling that over time will crescendo into an overflow.
Yep. And I'll tell you, one particular reason I really love the fasting insulin test is because it's kind of a linchpin test in that, let's say we've got a patient who has a family history of type 2 diabetes, and they're like, hey, doc, I don't want to get diabetes. And the doctor's like, oh, okay, well, here, let me go ahead and give you the American Diabetes Association handout, right, of the diet that they recommend. And the patient's like, yes, yes, please give me that. I'm going to go ahead and start eating that way to prevent type 2 diabetes from happening, right? So then if you and I and patients are able to educate that doctor to check a fasting insulin, you know as well as I do that the recommended diet of the ADA is quite high in carbohydrates. And for somewhere between 60 and 80% of the people who eat the way the ADA tells them to, they're going to develop hyperinsulinemia. And so if a doctor checks that fasting insulin and it comes back 25 or 30 or 35, and the patient's like, whoa, wait a minute, I'm eating the American Diabetes Association recommended diet. That's going to be a red flag to that person. Like, that's really odd. I mean, is there something wrong with me metabolically or genetically? But it's also, and this is the reason I really love it, is the average doctor, you know as well as I do, they're just going along to get along, doing their thing, what they were trained to do, just kind of rote memory, follow the algorithm. But that's a red flag. Like, whoa, why is their insulin so high? That's odd. And any kind of a good doctor, because some doctors are not good doctors. Some doctors are lazy. They're distracted. They've got a substance use disorder. But any good doctor is going to go, what in the heck? And when they get home that night, after they take care of all their other duties that doctors have, and there are many of them, they're gonna Google that. They're gonna look that up. And what is hyperinsulinemia, and how is that connected to diabetes or diet or whatever? And then that doctor all of a sudden is starting to kind of rediscover the physiology textbook, that's my ultimate goal, because most doctors, once they get out, they never ever think about actual foundational physiology again. They just follow the algorithms. And, any monkey can follow an algorithm. And what I love to tell family doctors is, AI can follow an algorithm. So you better watch your step. You better not become too complacent following that algorithm, or
Yeah.
you, my friend, will be replaced.
Yeah. And for those, I guess, listening from Canada, it's going to be hard to convince your family doctor to order it, but you can offer to pay for it out of pocket. I don't think
Yep.
it's going to be too expensive. The big thing is, are they going to be willing to interpret it? I think they would say, we weren't trained to interpret it. That's more of endocrinology.
Uh-huh.
And then you're going to have to accept or push back and say, doc, I want this. I can look into how to interpret it. And that's your battle between you and your doctor.
Exactly. And I would prefer it not to be a battle, but sometimes it winds up being a battle. I'd prefer it to be a discussion, right? And a discussion that spurs interest in both the patient and the doctor. And they both go back home and do some more research and then meet again in 3 or 6 months and discuss it some more. That's what I would love. That's my goal. But sometimes it does wind up, it becomes a battle, and the patient winds up firing a doctor or vice versa. And sometimes that's for the best, but I would hope that's in the minority of cases.
Yeah. So in this situation, let's say the patient gets their fasting insulin, it is elevated or elevating over,
Yep.
you look at the trend.
Yep.
What are the steps that you would recommend in terms of nutrition, even exercise, but mostly nutrition, that's your focus right now, for that patient to improve?
Yeah. So the vast majority of improvement, first of all, I would like for the patient to be thoroughly worked up by somebody who understands kind of the physiological pathways that could lead to hyperinsulinemia. And that includes endocrinological diseases, right? So maybe a referral to endocrinology just to rule out that you have an insulinoma or you have, some kind of pancreatic disorder. But then once all that very, very rare stuff is ruled out, you're left with the very, very common cause, the most common cause of hyperinsulinemia, which is carbohydrate overdose syndrome, which is what I think type 2 diabetes is, carbohydrate toxicity syndrome, where you're just eating
Mhm.
too many total carbohydrates for your personal physiology. And I think there's a valid argument to be made. Maybe you're just eating too many simple, ultra processed carbohydrates. And I think for probably 60% of the people with prediabetes or type 2 diabetes, that's in fact the case. I don't think everybody needs to be a carnivore.
Mm.
I think many people, if they just cut out the ultra processed, just sugar added junk food, they're going to reverse their hyperinsulinemia and reverse their prediabetes. And then as long as they continue to eat like that, they probably won't ever develop type 2 diabetes. But there is a subset of people, somewhere between 10 and 30%, that even not eating the ultra processed junk, if they're eating lots of fruits and drinking lots of fruit juice and having fruit juice smoothies and eating lots of whole grain bread and whole grain tortillas, they're still going to be hyperinsulinemic and develop prediabetes. And for those people, they may need to adopt a ketogenic diet or even a ketovore or a carnivore diet. And I just think it pulls back the curtain for people because even, let's just say there's a patient who's a truck driver or who bags groceries or who's a hairdresser. They have no education in human nutrition or human
Mm.
physiology whatsoever. And they get a fasting insulin back that's 35 or 40. They can just do a quick internet search or they can ask Chat GPT, what are all the things that can make my insulin level high? And there's the list. And then they start saying, well, I definitely don't have that. I don't have that. Here's 5 things I don't know if I have or not. I need to talk to my doctor about that. But one of the things that's going to be listed is a diet that's too high in carbohydrates. And so at least the answers in that multiple choice list, whereas before they didn't even know they had a problem, right?
Yeah. Yeah. Is there anything other than nutrition that can cause insulin to increase over time?
So there's a short list of very rare conditions like insulinoma I alluded to earlier.
Yeah.
But for the vast majority of people, it's just eating too many carbohydrates, probably definitely too many simple ultra processed carbohydrates. And definitely if exercise can lower your insulin level because it helps you store the glucose sooner in the muscles, right? So you're not going to have as high of an insulin spike. So if you join the gym and start going regularly and working out, that is going to lower your insulin, but it won't lower it back to normal. There's only one thing that'll do that, and that's consistently eating a diet that's low enough in carbohydrates for your personal physiology. And I think for some people, that's under 100 total grams a day. For some people, they have to cut it more. For some people, even more than that. But that is the easiest intervention. And now some people would argue with that, right? And be like, well, it's not easy to change your diet. But I think that doctors have this false sense that nobody's going to change their diet.
Yeah.
And here's why I think doctors have that false assumption is because they've recommended diets to patients in the past. And the patients either didn't follow the diet or they followed it for a while and then stopped. But my contention would be there's 2 reasons why the patient stopped. Number one, most diets that doctors recommend are semi-starvation diets, meaning you should stop eating before you're entirely full or satiated. That's not a normal thing for a mammal to do. No other mammal on planet Earth stops eating before their belly's full. So how can we expect humans, who are also a mammal, How can we expect them to do that? Having prediabetes and type 2 diabetes is not a question of gluttony or sloth. That's not what causes it. And so that's number one. And then number two, if you recommend a diet like the American Diabetes Association diet, I'm sure Canada has a similar diet plan, and their diabetes doesn't get any better, they don't lose any weight, they don't feel any better, then why would they continue to eat that way? Because it's
Yeah.
a restrictive diet. It's telling them not to eat certain things, but they're not any better. There's no measurable way that their health improved when they started eating that diet. So why would they? It would be a little bit psychotic for them to continue to eat that way if it didn't have any demonstrable benefit to either their symptomology or the signs in the labs or the signs when the doctor does a physical exam. Why would they continue to eat that way? Does that make sense? And so I think that's the two biggest problems. And that's why so many doctors are jaded. They don't even want to talk about dietary interventions because they've tried that 100 times and the patients don't stick with the diet. But the problem is it's not the patient's fault because the doctor recommended a diet that's either abjectly impossible or highly improbable that a patient could eat that way for the rest of their life, or it's a diet that had no benefit. So why would the patient do it?
Yeah. And I think also when we were doing our quality improvement projects in first year, they said, kind of what motivates people to change. And they would say patient education was always gave the worst outcomes because you just say it. Now, we can make that better. If I'm seeing a patient, we can do blood work to show evidence, some more counseling, frequent appointments for kind of a behavioral encouragement and counseling. But yeah, just to say eat less and move more, definitely you're going to get worse results. You're not going to get the results that you wanted. Based off what we're talking about, I like that you mentioned you don't want or you don't think everybody needs to be on carnivore. I think it's very easy once we start listening to these podcasts to be very tribal and say, carnivore is the only way or plant-based is the only way. I like finding that somewhat middle ground, probably more animal-based skewed,
Yes.
but it leaves room for people to play around. And
Yes.
so my question is, how would you maybe talk to a patient or a client of yours that is, eating a modern diet? Would you say start to transition slowly, or would you say go cold turkey straight to carnivore, and then you may have like the keto flu and all those things that come with it?
It depends on the person's personality type. And if you're a good doctor, you can pretty much tease out what kind of personality your patient has. If they're a teetotaler and they're gung ho and ready to do something that's going to make a noticeable improvement in their health, I'll tell them to just go ketovore or carnivore, which are super low carb options. But if they're more of a moderator and they like to, they're not the type that jumps into the pool, they stick their toe in and check it out, then I'll say, okay, well, let's stop any food in your diet that has added sugar. If it's got added sugar, take that out of your diet because reality is food is supposed to be nutrition. And so any patient, even if they could care less about their health, if you say, hey, you know what? Jelly donuts and Doritos and Pepsi Cola, those are not real foods, right? You understand that, right? Those are not foods. Those are treats. Those are things that big food sells you to make a profit. You understand that. And anybody that they dropped out of school in 8th grade and never thought about nutrition, they're going to go, yeah, I know. I like them, but I know you're right. Everybody knows that. So we're going to start there. Any added sugar, just get rid of that. And then if it has grains, wheat, rice, oats, and corn, those are more poverty foods. Those are starvation foods. You eat that kind of stuff if you're so broke you can't afford real food. Ramen noodles, stuff like that. You don't eat that. That's not health optimization food. And the average patient, regardless of their IQ or education, is going to go, yeah, I see what you're saying. I want
Yeah.
to eat food that has lots of nutrition. I'm going to say that's right. And then the third principle would be let's not eat things that have just been invented in the last few decades. Let's eat things that humans have been eating for a long damn time, thousands of years. And so that brings the vegetable seed oils into question because some of them we've only been eating for 2 or 3 decades. So you cannot make an argument, oh, that's an ancestral food. We've been eating that. Your great, 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 great grandmother ate that. No, she didn't. She didn't even know that was a thing because it didn't exist. And so if the average person who's a moderator, I'll just say, let's cut out the added sugar. Let's cut out the grains, wheat, rice, oats, corn, and soybean. And then let's cut out the vegetable seed oils. Because if you think about that, if they cut out or cut way back on those three things, what's that going to eliminate from their diet? Almost completely any ultra processed food whatsoever. Because it's all made from some combination of those three things, right? So we've got all the ultra processed junk food out of this patient's diet. And I always make it a point to say, look, you're a mammal. You should eat until you're full. And a lot of patients are blown away when I say that. They're like, no, you don't know me. I'm like, yeah, I do know you. Maybe not personally, but I know your physiology. And unless you have a genetic defect or a brain tumor, you're going to be able to stop eating when you're truly full, unless you're eating hyperpalatable, ultra processed things that cause you to overeat your satiety hormones. I do know that about you. And it might take you a week or two or a month or two for your body to kind of reconnect your brain and your gut and say, oh, okay, I now know what it feels like to be truly full, and I know what it feels like to be truly hungry. But once somebody reconnects that gut brain axis, they're like, yeah, when I eat, meat and eggs for breakfast, I'm able to stop eating when I'm truly full. But if I have pancakes and syrup and biscuits and gravy and, all these things with jelly on top of it, I can just keep eating and eating and nibbling and nibbling. And before you know it, I've eaten way more food than I should have eaten. Right. But if you eliminate just those three ingredients, all of a sudden, you're able to kind of hear your body's feedback again when it comes to, are you truly hungry and are you truly full?
Yeah. I laugh because when I talked to Dr. Anthony Chafee, I told him, when I eat a bag of goldfish, I can just keep going. This past weekend, I was camping, so we take chips or different things, and I could house a bag of Doritos, just keep going. And I'm like, you shouldn't be eating it. You're camping, so you kind of have a little bit more leeway. And you keep thinking about it, but it's like the sugar, the salt, whatever they put in there, they are good at tricking your brain to just keep on eating. Over the last few podcasts, more than 96% of viewers haven't subscribed to this channel. I'd like to reduce that down to 50%. So if you enjoy any videos on this channel, please subscribe, hit that notification bell, and comment below what videos you want to see in the future.
And it kind of freaks some people out. Some patients, when they go down this kind of avenue of discovery, and they discover that the big food corporations actually employ food chemists to make the food hyperpalatable, to make it so that it can override your satiety hormones. And many doctors don't know this either, that they pay food chemists and food scientists hundreds of thousands of dollars a year to make the Doritos. So they're going to keep eating until you've eaten the entire bag and then wish you had another bag. That you can sip on the Pepsi or the Coca-Cola all day long and you never get tired of it. Real food's not like that. If I cook you a perfect ribeye and some perfectly grilled broccoli, you're going to love it. It's going to be delicious. But when you've eaten enough of that, you're going to say, oh, I can't eat another bite. I cannot eat another bite. I'm so stuffed. But then if I pulled out the Doritos and the Pepsi and the jelly donut and said, well, try a bite of this. Well, by gosh, you could wind up eating the whole bag of Doritos. But I thought you said you were stuffed and couldn't eat another bite. How is it that somehow magically you're now able to eat a whole bag of Doritos, drink half the 2-liter Pepsi, and eat the jelly donut? I thought you were stuffed. Evidently you weren't. Well, actually you were. But those products, and I try to educate people, don't think of them as food. They're not food. They're products. Yeah. Those products are designed to make you overuse them, just like illicit drugs are designed to make you overuse them.
Yeah. You mentioned, seed oils are relatively new for humans, One thing that I struggle with, because I try to, and I'm sure you do too, is listen to both sides of the argument. There's a lot of the people that are pro seed oils, or at least not anti, will say, the current research
Right.
shows that it's not really that bad. And
Right.
then we have the more animal based people that would say, no, it's probably bad. And even if we don't have evidence for it, we should still avoid it because we don't really know what it's doing. How do you navigate that?
Most people get the ancestral arguments, and I use an analogy like, let's take the cow. Cows eat grass, right? And everybody's like, yeah, cows eat grass. And I'm like, what if I came up with this new food for cows in the factory and you're a cow farmer and I said, hey, this new food is much healthier for cows. I just invented it. And you're going to have to buy it and pay for it. The average cow farmer would be like, yeah, I need to see some research on that. Right. And I'm like, well, I've got all this research, but I funded it. The guy who invented the food and who's going to profit from the cow food that I have told you is better for a cow than grass. Now you can buy it because there's all this research. And the common sense person is going to be like, but you paid for the research and you designed the research and you're the one who published the research. You own stock in the company. I feel like the laws of human nature tell me that you might have a perverse incentive to trick me into feeding my cows this new fake cow food instead of just letting my cows eat grass, which is free. People get that kind of argument. They're like, I see what
Yeah.
you're saying. No, that makes good sense. And then when somebody like me or you starts to look into the research behind the vegetable seed oils, and you realize that especially the initial research was all funded by the canola companies that stand to profit from this, or the cottonseed companies, or any of the companies that have these vegetable seed oils. That's who funded and in many cases designed and conducted the research. So immediately, if you understand the laws of human nature and the law of profit, you immediately understand, well, that research might be sketchy. So maybe I
Right.
shouldn't. And then also, there's not a single control trial that pits beef tallow versus canola or butter versus cottonseed oil. There's not a single long-term control trial that pits these two against each other. So we have no control research, and every doctor should know that if it's an epidemiological study or an observational study, that doesn't prove a thing. My first
Yeah.
year of medical school, we had a class that taught us the different kinds of research studies and the strengths of this research versus that research. Every doctor should have had that much education, or they've just read enough research articles in the journals. They should just know, oh, this is an observational study. It's got 100,000 participants, but that doesn't make it a stronger study than a randomized control trial in 100 people. That's actually a stronger study, right? And so the average doctor, the average nutritionist ought to know that. But I don't expect the average person walking the street to know the difference. And so that's one of the reasons I've got so many YouTube videos talking about all this research, is to try to help people understand you got to look at who funded the study. And instead of putting who funded the study at the very top of the study, which you would think, just like a race car driver has Pennzoil right here, right? Because that's who sponsored them. You would think that the research studies would have who sponsored the study, who paid for it, who designed it right at the very beginning,
Yeah.
but they don't. It's down, it's buried all the way behind the citations in the very, very back bottom where most people never look. And I think that's a problem. I think that's one of the many things that needs to change.
Thank you for that answer. In between that answer, you mentioned, butter, and that made me think of saturated fat, and other kind of buzzword that a lot of people like to say. You could eat animal based, but the issue is you're eating more saturated fat, and that could increase your LDL or ApoB,
Mhm.
LP little a, all these different markers that the mainstream evidence, like that's most of the evidence that cardiologists go off of, really don't like. They still say saturated fat is bad. I talked to a cardiologist I worked with. I'm like, hey, do you know about the triglyceride HDL ratio? Never heard of it. I think I even showed him a study. He didn't really care much for it. How do you approach, when people, like, especially because I ask this kind of, a lot of these questions are selfishly because as a young doctor with this different mindset, I am stuck in the middle of wanting to help patients, but then also having other colleagues kind of judging me, and also are ruling like for us, it's the CPSO, the college, kind of judging me too if I recommend something that goes against the guidelines. What do you see both in the evidence you look at, but also in the patients that you look after or people share in your community in regards to like these cholesterol markers?
So, first, there's the ancestral argument, right? Human beings have been eating saturated animal fat for thousands or millions of years. And so, right off the bat, you're saying, oh, wait, we've discovered that this fat that humans have been eating since we've been a species on this planet, we've discovered that that's bad for humans. Most people who have common sense are like, that don't make no sense. That would be like saying, oh, we've discovered that drinking water is bad for you. Well, you should drink Coca-Cola instead. Well, what? How's that make any sense? We've always drank water. We've always breathed air. We've always eaten animal fat. How can that now be bad for me? And so the average patient's going to have no clue how to interpret and how to tease through this argument. But it's my opinion that the average doctor, especially the average cardiologist, ought to be able to tease through this and figure this out. So you've already discovered this, but many primary care doctors, they just assume that endocrinologists or cardiologists, that they have parsed through all the data in their specialty. And like you were probably surprised that the cardiologist you were talking to has never heard of the triglyceride to HDL ratio. And you're like, that's wow. How do I know it and you don't know it? That's weird. What primary care doctors need to understand, what mid-level providers definitely need to understand, and what patients need to understand is that the most preeminent cardiologist in your country, the majority of the time, they just follow the guidelines. They're not thinking this stuff through. They're not sitting at home at night studying and looking up studies and trying to go back to their physiology textbook. And does this make sense? That's number one. They're not doing that. They should be, but they're not. Probably the specialty I'm the most disappointed with is the endocrinology. When it comes to thyroid treatment, when it comes to sex hormone treatment, and when it comes to pancreatic function and even adrenal function, they're not digging down into the deep physiology, cell and molecular biology. They're just not doing that. They're just following what their association tells them to do, and they're not thinking this through. And that's very disappointing. So here's another thing that you would think the average cardiologist would know, since it's come so quickly to their lips to denigrate either a ketogenic diet or a carnivore diet. They should know the data behind those diets, right? They shouldn't be denigrating them if they don't know the data. And so the average cardiologist, probably the one you talk to, if you said, what percentage of people, if I put them on a meat-heavy ketogenic diet or a fatty meat carnivore diet, what percent, if I put 100 people on one of those diets, what percentage of them do you think their total cholesterol and their LDL cholesterol would go up, doctor? You know they're going to say, oh, God, 80, 90%, maybe 100%, right? So they don't even know the basic physiology of this, because the truth of the matter is, if you put somebody on a high-fat, meat-heavy ketogenic diet or a high-fat carnivore diet, if you put 100 people on there, about 33%, their cholesterol and LDL is going to go down. And about a third of people, their total cholesterol and LDL cholesterol is going to stay about the same. It's not really going to change. And about a third of people, their numbers will go up. And then about 1% of the people are lean mass hyperresponders. Their LDL and total cholesterol is going to skyrocket. So right off the bat, the average cardiologist has no idea that a third of people's cholesterol is going to go down if they start a high-fat keto or carnivore diet. They don't know that. And so how can they then be trusted to give a patient dietary recommendations when they don't even know the foundational physiology behind what's going to happen to a patient if they recommend a certain way of eating? That's one of the basic problems. And I think that if a doctor hasn't really studied nutrition, they shouldn't even give nutrition advice. And that goes for all specialties, especially if you haven't really looked into diet and nutrition, you shouldn't even make a recommendation. You should be honest. You should say, I have no idea what diet is best. I don't know what you should eat. Just, I don't know. Google it, watch some YouTube videos, because I truly don't know. I don't care about diet. I think if doctors were more honest like that and say, look, I'm board certified cardiology. I don't know anything about diet, and I'm not going to learn anything about diet. That's on you. You gotta figure that out.
Yeah, that'd definitely be
That'd be a
helpful.
much more moral stance, don't you think? That'd be much
Yeah.
more ethical to just admit to the patient, look, the only thing I know about diet is I watched the What the Health documentary and I watched that plant-based documentary. But as far as reading all the nutrition research, I haven't done that and I'm not going to. I haven't gotten my physiology and nutrition textbook, if you even had one. I haven't gotten those out and really looked at this. I have no idea about diet and I don't care. You figure that out on your own, or I'll refer you to a dietitian. That'd be a much more defensible position for a cardiologist or an endocrinologist or a primary care doctor to just say, I don't know and I don't care. I'll refer you to somebody if you want to look into that deeper. But doctors don't do that. They'll watch What the Health, or they'll watch, the Game Changer documentary, and they'll start to give dietary advice to their patients based on a documentary they saw. And that's ridiculous. I don't want doctors to watch the animal documentary and then start giving nutrition advice. That's not how you should do it. A doctor should know better than that. Now, the animal documentary might spur your interest and you're like, I've never heard of that or thought about that. I'm going to look into that. Right? That's what the documentary should do. It should not make doctors go, okay, I'm just going to start recommending carnivore. I'm not going to look into it.
Yeah.
No, I don't want that to happen. And you won't serve your patients if you do that. So please don't do that.
Speaking of the animal film documentary, in that film, I watched it 2 days ago. You said there's no signal suggesting that carnivore increases heart disease risk. Is there, are there studies that look at that? I know there's a keto trial, which is not carnivore, but it's keto, and carnivore, a good carnivore diet is keto. But also, what are other medical conditions that you have seen improved, reversed, or stopped for people being on carnivore?
So many. So let me first say this, because I'm sure you have a few medical students and residents and young doctors who watch this. LDL cholesterol is a proxy marker for heart disease. You have to understand that. ApoB is a proxy marker. If somebody's ApoB is elevated, that's not like, boom, guaranteed heart disease, guaranteed, elevated CAC score. The lean mass hyperresponder 1-year follow-up study showed very clearly that you can have a sky-high ApoB or sky-high LDL. And if you are in the lean mass hyperresponder cohort, which is a very small percentage right now, your CAC score is not going to progress. You're not going to lay down more calcification just because your ApoB's high or your LDL's high. And they're going to come out with a 2-year follow-up, 3-year follow-up. There's more research coming. And so that's the first thing, is I want any healthcare provider to understand these things are proxy markers. They're not like, aha, I have discovered something. That's just a possible risk factor. Just like having an elevated uric acid level, that doesn't mean that patient has gout. There's 100 things that could cause the uric acid to be high. I've seen patients who had high uric acid for 20 years and never had a single gout attack. Any doctor who's been practicing for a long time, is like, no, that's right. I've seen that. Doctors got to stop being lazy. They've got to start understanding these things are proxy markers. They're not guarantees. You haven't uncovered something. You've just said, oh, this patient's at a little higher risk for this probably because of this proxy marker. We need to do further testing, or we need to have a conversation. That's the first thing. Now, when I first started recommending ketogenic diets and then later a carnivore diet for people, I considered them to be just temporary weight loss hacks because I didn't know a damn thing about nutrition. I had forgotten all the physiology, all the biochemistry, the cell and molecular, how the food interacts with the human body. Either I'd never been taught or I had forgotten it. Right. So I just thought, oh, you cut the carbs, you lose some weight, then you can go eat the American Diabetes Association diet, I guess. I don't know. But I kept having patients come back, and this is that signal that I talk about. I would have a patient who had lost 30 or 40 pounds with either meat heavy keto or carnivore, but also their reflux symptoms had either gotten much better or went away, or their eczema cleared up, or their severe shoulder arthritis that they were considering having a reverse joint replacement for.
Oh,
It just stopped hurting. It wasn't hurting anymore. Initially, and every doctor, when you hear something like that, you're like, yeah, anecdotal, that probably doesn't mean anything. Or we all know, any good doctor knows that patients will blow smoke up your rear, right? They just like, oh, I love you, doctor. You just, and then we got the placebo effect to contend with, right? So there's
yeah.
all these things that muddy the water. That's true. But I kept hearing this signal, kept seeing this signal over and over and over and over. And then I had 2 or 3 patients with eosinophilic esophagitis, which has a black and white on the CBC with differential black and white. Their eosinophils are elevated every single time I check this lab. And they have severe reflux symptoms, right? I had 3 of these guys who were all taking either Nexium or Prevacid or something. It went completely away. Not only did their symptoms go away, which is a subjective thing for a doctor. I'm like, well, maybe his symptoms went away, but I'm not in his body. I don't know. But then I would check his CBC with diff. His eosinophils are now normal. That's objective. That's black and white. He can't fake that. Right.
Yeah.
So I'm like, dude, how is this happening? How is this dietary intervention, which I'm telling people to do it just to lose 30, 40, 50 pounds? But also when I checked their A1C, it used to be 8. Now it's 5. Reverse their type 2 diabetes with a temporary weight loss hack diet. What's going on here? And so that's what really caused me to pull out the big fat textbooks on physiology and biochemistry. I'm like, there's more going on here than them just cutting carbs and losing weight. Because if a patient had severe knee arthritis, and I put them on keto or carnivore and they lost 30 or 40 pounds, and they came back and said, hey, doc, my knee, I have no knee pain anymore. Well, you'd say, well, you've unloaded a lot of weight from that knee, right? Because they've lost weight. But you can't say that about shoulder arthritis unless they walk on their hands all day. And, the third most common joint is right here. You can't say, well, it doesn't hurt anymore. Well, that's because you've lost weight. What? No, there's got to be something else. There's got to be something physiological going on with this diet. It's got to be, there's some cell and molecular biology changes going on here. What are they? And that's what really enticed me to start really digging deep. How does a meat heavy ketogenic diet, how does it make shoulder arthritis not hurt anymore or hurt 80% less? How does it make this thumb arthritis hurt so much less that they cancel their joint replacement surgery? How is that possible? And that's when you start thinking, well, maybe meat, instead of being inflammatory like we're taught, right? Either maybe not taught in medical school and residency, but taught by that What the Health video and taught by
Yeah.
the Game Changers documentary, that red meat's super inflammatory. Well, what if that's not true? And when you start thinking rebellious thoughts like that, it encourages you to start pulling out the textbooks and to start doing internet searches, or to start talking to your chat GPT and say, look, I don't want you to give me answers that are very popular or that are in mainstream media. I want you to dig deep into the basic physiology and biochemistry of the human body and answer my questions based on that. All of a sudden you start getting these answers like, yeah, this is anti-inflammatory. This lowers levels of inflammation. This lowers HSCRP. This lowers ferritin. This lowers homocysteine. It might raise their LDL, but
Hmm.
how many primary care doctors are now aware that the predominant cause of heart attacks is inflammatory in nature? Like, you keep hearing that bandied about, but for some reason, the American Heart Association doesn't talk about it much, right? They're like, well, maybe statins have their effect. Maybe they have a anti-inflammatory effect. And you'll read something like that in an article every now and then, but then it just kind of peters out and goes away. And you're like, well, I don't know. I'm just going to put them on a statin because that's what I'm supposed to do. But you'd never think, well, what if their diet is causing this chronic inappropriate inflammation in their diet? When you start thinking like that, it starts making you search for answers kind of outside the box, so to speak. And I think that's the kind of a baseline marker for a really good doctor, is when they start seeing lots of signal come back from some intervention that they've recommended. You need to look into that. Why am I getting that signal? Because if one patient comes back and says, man, I started keto and my shoulder arthritis got better, of course, you're not going to waste your time looking into that. That's a single anecdote. But what about when the 10th person comes or the 50th saying, oh my God, not only did I lose weight, not only did my A1C improve, but my skin condition got better, my joint condition, my gut condition got better. At some point, if you're a good doctor and you're not just lazily following the algorithms, you're going to look around and go, what's going on here? How is this diet causing this? And that's why many of the doctors, my colleagues in this space who are doing YouTube or Instagram or TikTok or Twitter videos or posts, they saw that signal and they're like, wait a minute, how's this happening? And I want every medical student, resident, young physician, if you recommend an intervention to your patient, I want you to understand this. If you recommend an intervention to 100 of your patients and you see them for 3 months, 6 months, 12-month follow-up, and you get no signal from that intervention, right? Nothing. They don't feel better. They don't look better. Their health is not improved. You should think about that. You should be like, well, I know the algorithm tells me, the guidelines say to do this, but have I truly helped this patient be healthier? Right? You should ask yourself that question. You shouldn't just be like, well, that's what the algorithm says. That's what the Canadian Association of Fill in the Blank says. So I'm just going to do that because I don't want to get in trouble with the medical board, because I think that physicians in Canada probably took an oath, just like the physicians in America did. And at some point, if the guidelines are not helping your patients, and definitely if the guidelines are harming your patients, don't you have an ethical and moral duty to do what's right, regardless of if you might get a visit from the medical board? I feel like you do, but a lot of doctors are going to be like, whoa, no, 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 no. I'm not going to do anything that's going to get me a visit from the medical board. I'm not going to do that. Well, okay, I guess just go along to get along and keep your head down and follow the algorithm. But keep in mind, AI can do that better than you can.
Yeah.
And so just, young doctors, I don't envy them right now, because they've chosen a career which can be so rewarding, but it can also be so frustrating. And now they've got this new competitor on the scene that literally has no emotions. It does not care. It does not care if it puts you out of business and you have to declare bankruptcy and you can never pay your student loans back and you can never have the degree of satisfaction that I have knowing that I've helped so many people improve their health. You don't get that because you followed the algorithm and now you've been replaced by AI. So I guess you can now go to law school or something else. I don't envy young doctors unless they're willing to really put on their thinking caps and say, I can't just go along to get along. I'm going to have to carve out a niche for my own self here. I'm going to have to maybe not buck the system. I'm not suggesting that. I'm just saying you better have your thinking cap on. You better be thinking. You better be looking for signal coming back from your patients. You better be thinking about all that stuff or you will get left behind.
Yeah, and that's definitely something I want to do, because here in Canada we have it's mostly kind of government funded health, which then really limits what you're able to do and what you're covered. So we're not really paid to do nutritional counseling. So if I
Right.
want to do that and make it worth my time, I'd have to charge my patients privately or set up a clinic where it's just like private pay, because if the government covers for it, you can't charge privately for it. It's kind of messy to navigate, but that's why I like to talk to so many people and other Canadian doctors to figure out, geez, like, what am I going to do? Because I don't want to just set up a family practice for 30, 40 years and do the same thing, especially when I know so much about metabolic health. I have this interest. I'm interested in regenerative medicine, like different injection techniques as well. So I want to figure that out. I know we're kind of I'm mindful of our time, so I want to ask you some high yield questions here and then some more rapid fire about your personal kind of life. One thing that, when I talked to Zoe Harcum about this, a lot of people in the comments said, oh, how did you not talk about the microbiome? Because she was saying fiber is not necessary. It's not essential. And we didn't. I forgot to ask. So what are your thoughts on the gut microbiome and fiber and the phytochemicals that plants have? And is it necessary? Because you're obviously not getting most of that with a carnivore diet.
Yep. So the first question is, what's the list of phytonutrients that are considered essential in the human diet? And so the word essential has a specific meaning. It means that the human body can't make it. Number one. Number two, that it is essential to the human body. And number three, if you don't get that, whatever that phytonutrient is, you'll get sick, you'll suffer, and you'll die prematurely. Okay. So DHA is a fatty acid. The human body can make that to some degree, but we still need some in our diet. But there are some things like vitamin A that the human body can't make. Some of us can convert beta carotene to vitamin A pretty good. Some of us cannot, but we need to have vitamin A in our diet or we'll get sick and suffer and die prematurely. That's essential, right? So what's the list of essential phytonutrients? Well, there's not one. Not a single one of the phytonutrients is considered by the National Institutes of Health in the US or whatever the obligatory organization is in Canada. None of these are considered essential by that more technical definition. Fiber is also not considered essential, right? No regulatory body says, oh, you must eat this much fiber a day or you will get sick, you'll suffer, and you'll die prematurely, like vitamin A or vitamin E. It's not a real thing, right? Now, a lot of the organizations will recommend that you get so much fiber or that you get these phytonutrients, but nobody says it is essential. Now, so right off the bat, it's not essential. No phytonutrient is essential. No fiber is essential. So that's number one. Number two, if indeed fiber were essential, then there's over 1 million people on the planet right now who eat a carnivore diet and who have been eating a carnivore diet for a year or longer. So if you had to have fiber or some of these phytonutrients, which are also called phytochemicals, and some people call them phytotoxins, but they're all the same thing. If they were essential and your gut microbiome were going to get all screwed up if you didn't eat those every day, we would see a very large signal, again, with that signal, from the carnivore community. So after a person had been carnivore for a year or 2 or 3, they would just be getting sicker and sicker. Their gut symptoms would be getting worse and worse. Their skin would be getting worse, everything, right? Because you got to have that for good health. But we don't see that in the carnivore community. And then anybody who's not a medical person watching this, listening to this would say, well, that's weird. You would think that the doctors who believe that a vegan diet or a plant-based diet is best, they should be studying this carnivore community, right? The National Institutes of Health, they should give $2 or $3 million to study why aren't these carnivore people who have been carnivore for 3 years, 5 years, 10 years, how are they not deathly ill? It looks like the rates of colon cancer would be sky high in carnivores. Right? That stands to reason. Why isn't anyone interested in studying this carnivore community? Only carnivore doctors are interested in studying the carnivore community. But you would suspect that all of the plant-based or vegan promoting cardiologists, gastroenterologists, endocrinologists, they should be on fire signing up these carnivores for studies, because you would think that they would think that it would prove that you've got to have fiber or you've got to have phytonutrients, right? But for some reason, none of the plant-based promoting cardiologists or endocrinologists or gastroenterologists, they have no desire to study this million-member carnivore community for some reason. And I think it's because maybe unconsciously or subconsciously, I don't think they're consciously thinking, well, that'll prove me wrong. I don't think they're thinking that, because I think they're good, ethical, moral people, but they're also lazy and they're busy, right? And so I think they know intuitively, I probably don't need to do that study, because that would prove, or at least strongly suggest, that fiber's completely optional. And for some people, it's detrimental. And that all these phytonutrients that I'm telling my patients every day, oh, you need to eat the rainbow, all the different colors of plants. You want as many different phytonutrients as possible. that may be bogus advice. It may be that these carnivores who have eaten nothing but red meat and eggs with the yolk, they may not show any deterioration in their health at all. In fact, they may be very healthy. Then I might have to change my recommendations to my patients. And so I find it very telling that nobody wants to investigate this million member strong carnivore community, because if you truly believed as a physician that plant-based is best, what better place to research? Just go and sign up, 200 or 300 of these carnivores who have been carnivore for 3 years or longer, pay them $500. I want to draw your blood. I want to check your CAC score. I want to check these markers. You should be able to just show, oh my God, these carnivores are falling apart health-wise, right? That should
Yeah.
be easy to prove, but nobody's interested. I've yet to have a call from a vegan cardiologist or a vegan doctor at all saying, hey, we want to study you guys because you should be dropping dead like flies. And it seems like you guys are super healthy, and that's weird. And I want to study that.
Yeah, hopefully somebody eventually can raise enough money and interest to study that. It seems like a lot of people would rather debate with the current
Yeah,
research that obviously
right.
leans
But do
towards
you see
what.
my point, right? Of course, the doctors who are espousing a ketogenic or a carnivore diet, of course we're wanting to raise money, and we are raising
Yes,
money. We're crowdsourcing. We've got several studies already on the books. I've got 2 studies right now that I'm a part of that are going to be published when they're finished, regardless of the results, because I think you should publish your findings, whether it shows that you were right or shows you were wrong. I think both of those help advance nutrition and medical science. And I'm like, okay, let me give you an example. All doctors say, if you smoke crack, that's really bad for you. Okay, all right. But do you have any research to prove that? Well, yeah, actually, because doctors who believe that smoking crack is bad for you, they went out and studied people who smoke crack. And
right.
it's on the books. We've got research done by anti-crack doctors studying people who are pro-crack. And now we've got research that shows, just like smoking, most doctors are anti-smoking. Most smokers are pro-smoking, or at least they want to pretend to be. Doctors who are anti-smokers went out and studied people who are pro-smokers. And now we've got it's really all observational, but the hazard ratio was 20 or 30 to the point where you have to say, yeah, that looks pretty bad for you. So why don't we have anti-red meat doctors as eager to go study pro-red meat carnivore advocates? There's just nobody who wants to study that. That's weird, don't you think? We've got anti-crack doctors who they're eager to do the research on smoking crack. We've got anti-smoking doctors who are eager to do research on smokers. Why don't we have anti-red meat doctors who are eager to do research on red meat eaters, and not a mixed diet who has 8 ounces of red meat a week? I'm saying, why would you waste your time doing an observational study on people like that? Why not go where it's all red meat? Why not go to people who are 100% carnivore? Because that's where you should get the biggest signal from, right? Makes sense. Yeah, if a little red meat's bad for you, then a lot of red meat ought to be terrible for you. So I'm going to go study these people who eat nothing but red meat. And man, when I publish that research, it's going to become glaringly obvious that if you eat red meat, you get sick and you suffer and you die prematurely. And if you eat a plant-based diet, then you could have 2 cohorts. These people eat 100% red meat. These people eat 0 red meat. Let's follow that cohort for a year, for 3 years, 5 years, 10 years. That seems like the study, but what they always want to study for some reason is people eating a mixed diet, and they're eating 8 ounces of red meat a week, or maybe 16 ounces a week. But then they're eating all this ultra processed crap too, and then try to tease out somehow in that research. Why not go where the signal's at? That seems like a smarter choice.
Yeah, I agree. You make a great point. I want to transition to different category here of questions, maybe ones that you can answer with a brief couple of sentences.
Well, maybe I can because I'm not known for that, but I'll try.
I appreciate you're a very good teacher and you give very in-depth answers, which is very helpful. But these ones, I think specifically, you should be able to. What does a typical day of eating look like for you?
So I typically fast until somewhere between 2 and 4 p.m. And then when I break my fast, it's with somewhere between 2 and 3 pounds of fatty red meat. That could be ground beef or that might be some ribeye steak. And then I'll typically eat anywhere from 3 to 6 eggs with the yolk along with that. I typically drink black coffee in the mornings and then switch over to water after noon because I'm a slow metabolizer of caffeine. If I drink caffeine after lunch, I won't sleep that night. I'm very active on my farm. I work a lot, work out, and I don't work out in a gym, but I work out on the farm every day. So that's my typical day of eating. Now, every now and then, if my wife and I are out for a celebratory dinner or something, I'll eat something that's not meat. I'll have a bite of sushi or I'll have a bite of broccoli. I'm not a a fanaticist. My health does best when I eat almost exclusively red meat and eggs with the yolk. That's where my A1C stays perfect. That's where my weight stays where I want it to be. That's where my endurance, my stamina, they all stay perfect if I follow that way of eating. And again, let me repeat, I don't recommend that for everyone. I don't think everyone has to do that.
I appreciate you sharing that because one of my questions later on was, what do you do when you go to a family dinner or a friend gathering? And you obviously want to prioritize carnivore, but you also want to be part of the community. Do you kind of maybe cave in to some of the healthier options rather than jump into like cake or cupcakes
100%.
kind of thing?
Yeah, everybody at our church knows I'm never going to eat the cake or pie or the cookie. I'm just never going to do that. But I might have some of your homemade coleslaw, or I might have some if you made, some kind of vegetable that's lower in carbohydrates. I might eat a bite or two of that. If you made some sauteed mushrooms, I might have a bite or two of that. But everybody knows I'm not going to eat the cookies, cake, or pie. I'm just not going to do that because I don't consider that to be real human food.
It sounds like you drink coffee. You drink it black in the
I do.
morning.
Yeah.
Do you drink milk or eat cheese?
So full disclosure, I love all things dairy. I have never really found any dairy that I don't love. So with that, that's just for full disclosure. But I have found in my personal health journey that when I eat as much dairy as I like, I'm about 10 to 15 pounds heavier. And when I cut out all dairy except for just the dairy fat, so butter or ghee, then I hang out at about 6'3", 225 pounds. 220, 225, somewhere in that range. But if I ate as much cheese and put as much heavy cream in my coffee as I wanted, I'd be anywhere from 10 to 15 pounds heavier. And that would be kind of my baseline. And I feel much better and look much better in my blue jeans when I'm 220 to 225 than when I'm 235 to 240. And so I have to limit the dairy. And I think there's two reasons I'll hit quickly. One is all dairy contains casomorphins, except for butter and ghee, which can be habit forming for some people and give you that pleasurable sensation. And then secondly, the caseins and wheys for me are inflammatory. They cause me to hold excess inflammatory fluid. And for some people, I think it's fine to have full fat, fully fermented dairy or heavy cream or something like that. They do just fine with that. But for me, I know I have to limit that.
Yeah. Thanks for sharing that. For when you drink water, do you ever add electrolytes to that water, or are you not a
Yeah.
fan of
Yeah. And
electrolytes?
so if I'm going to be indoors all day just doing videos or conference calls, I probably won't. And I'll go for hours without drinking water. So drinking more water than your thirst dictates is not healthy. It's not that a lot of people think that's a health improvement hack to drink a gallon or 2 liters or so much water. That's foolishness. There's no research that supports that, and no other mammal does that. If you're thirsty, drink. If you're not thirsty, don't drink. Now, all the water we drank more than, 300 years ago had electrolytes in it. If you're drinking river water, stream water, pond water, puddle water, it's got electrolytes in it. It's got bacteria too. So I wouldn't recommend drinking it today. And so I mimic that old way by adding some unflavored electrolytes to water. If I'm out on the farm working in the 90-degree heat and sweating profusely, then I'm going to drink water, but it's going to be water with electrolytes.
Okay. Do you take any supplements, or do you believe that, kind of nose to tail provides everything you need?
I think nose to tail, including liver, you're going to get almost everything you need. But there's three things that even then, even with me working on the farm without my shirt on, I'm still not going to get enough vitamin D. So I replace iodine, vitamin D3, and vitamin K. I think I lost you. Are you there?
So unfortunately, Dr. Ken Bear's internet got disconnected and he was unable to connect again, and his schedule didn't allow for us to record that last little bit of the episode. If you enjoyed this episode, make sure to comment return Dr. Barry, and maybe he'll return on a future episode to answer any questions that you leave in the comment section. Reminder to subscribe, hit that notification bell, and make sure to share this episode with all your friends. Take care.